Hello, this is Amjad al-Mendilawi from Baghdad, Iraq, showing a session on stent dislodgement and the way to retrieve it. Our case was a 59-year-old female who was diabetic, hypertensive, and obese. She was referred to us as a case of inferior STEMI for a primary PCI. This is the right coronary artery. It shows total occlusion at the proximal part, and it has a shepherd crook appearance with some acute angulation at the proximal part. We needed some good support, so we tried to engage initially by AL guiding catheter, which has been kinked. This was from the right femoral approach. Finally, we managed to use a hockey stick guiding catheter, which gave us a good support. So the first thing was to wire and did some balloon dilatation because there was no flow using a 1.5 balloon 20 millimeter. And this was the result. As you can see, there is a large thrombus at the lesion. Usually in primary PCI, we are tempted to do direct stenting especially when we see a large thrombus. And this is what we opted to do in this case, which turned out to be not a good thing. So we tried to pass a stent 3.5 by 30, and as you see, it was difficult to pass across this calcification and this angulation. At this step, we tried to retrieve this stent and make full preparation of the lesion. While we attempted to pull back the stent, the balloon of the stent came out, but here you see this is the stent shadow, that is undeployed stent stuck and at the proximal part of the right coronary artery. So what causes a stent to be dislodged from its balloon? Usually the causes are coronary tortuosity and calcification, poor preparation of the vessel prior to attempt to deliver the stent, direct stenting, maybe a poor guide catheter support, forceful withdrawal of the stent inside the guiding cath, use of guide catheter extension, or stent advancement through a previously deployed stent, or sometimes, which is not commonly used, attempting to deliver equipment via the collaterals. So the algorithm for the management of stent loss depends on three things. First is the location of the stent loss, whether we need to retrieve or not this stent, and whether our wire position is maintained or not. And this is the algorithm. So if the location of the stent is outside the coronary, the stent has passed away into a peripheral artery, then we ask whether we need to retrieve it or not. If we don't need to retrieve it and it's a small peripheral branch, we can leave it there. If it's inside the coronary, again we ask whether we need to retrieve this stent or not. If not, and the wire position is maintained, then we can deploy the stent at that position. If the wire position is not maintained, then we pass another wire and crush it at that position. Then we come to the important question that when the wire position is maintained and we need to retrieve this stent, there are several ways, being the small balloon technique, a snare, or a twirling guide wire. If all these are not successful and still the stent is an important position and we need to retrieve it, then emergency surgery is the last option. So a retriever by a small balloon is that here we have our dislodged stent. We pass a small balloon with a low profile over the wire, passing distal to the stent, and then inflate this balloon and trying to retrieve the stent gradually into the guiding catheter. The other way is to pass a loop snare over the wire, over the stent, and then close the loop and try to retrieve the stent into the guiding catheter. The other way is a twirling wire technique. We have our wire inside the stent, then we pass another wire either through the strut or around, and then we twist two wires quickly, making some loop around the stent, and then try to retrieve it into the guiding cath. When we don't need to retrieve the stent and it's difficult, and whether the wire position is maintained or not, we can crush this stent by passing balloon behind it, crushing the stent, and then passing another stent to open the artery. So the solution in our case, we had two conditions. First, our stent is dislodged. The second thing is that it has been stuck in the calcium. So initially, we passed a small balloon 1.5. It was not possible to pass this part because this part probably has been crushed by the calcification. At this time, we made some angiography, and we see we are just at the OSM of the RCA. So we can deploy it here or we crush it here. So we tried initially to pass inside the stent with a small balloon, and then we passed another wire around the stent to keep a safe position for a crushing if we need. And gradual with a small balloon, we maintained our position, and with piecemealing, gradually pushing forward, we were able to pass a smaller balloon, 1.5 single dot 10 millimeter, finally passed distal to the stent. This is our balloon, and this is our undeployed stent. We inflated the balloon and tried to pull it back. During all these maneuvers, the long stent has actually been disfigured and cramped. So with forceful withdrawal, we were able to withdraw the stent from the right coronary. Now we have a dislodged stent that has been withdrawn by a small balloon. Keep it in the descending aorta, not to go to the carotids. This is the balloon, and this is the stent, and this is the guiding catheter. We pass it down to the descending aorta in an attempt to take it out from the guiding cath, and this idea proved to be not a good thing. The good thing would have been retrospectively that we snare it from the other side in the descending aorta. So we came out to the catheter, to the sheath, and we thought, you see, that we are pulling everything out into the sheath. But what actually happened is that our small balloon has ruptured and came out while the stent remained at the mouth of the sheath. And here's a larger picture. This is our stent, which is disfigured. It's at the mouth of the sheath. At this point, we stopped trying anything because we have an RCA occluded and the patient that need primary PCI. So we went on from the other femoral, and from the left side we could engage by the AL guiding catheter. We prepared the lesion well using the NC balloon and made some dilatation, but unfortunately, as we expected, that we had dislodged the thrombus and the flow was not good. Anyhow, we passed a stent 3.522 with full dilatation, but the patient has some no reflow. We went through all algorithm for treating slow flow and no reflow, and this was the final result. We accepted this final result and we stopped. The patient was stable, and then we turned back to our dislodged stent in the peripheral artery. During our attempt to open the RCA, the dislodged stent acted as a cell, and it pushed out our sheath. You see, the first position was here. Now our sheath is out, and the patient has a big hematoma. So we tried to retrieve the stent, and unfortunately, it was extremely difficult to pass from the left femoral to the right because of this angulation at the bifurcation of the aorta. This was very difficult using all equipments. We didn't have all the necessary equipment, and the catheter kept kinking even by using some strong wire and the balloon technique. Finally, we called the vascular surgeon and asked him about his opinion, and the consensus was that since there is no any extravasation, although the sheath was out, and the stent was in a smaller branch of the deep femoral artery, so we can keep it here and to do nothing anymore. The patient was stable and discharged 2 days later. So the lessons from this case is that prepare the lesion well before stenting, even in primary PCI. If retrieval of the stent loss is possible, then retrieve it. If not, crush or deploy the stent in a convenient place. A retrieved stent may not come out of the guiding cath, as in our case, so prepare for snaring through a larger guiding cath. And thank you.